My name is Emily Buchholz. I'm a faculty member at the University of Colorado Denver and an associate editor for JACC. It's my great pleasure to introduce Becky Josowitz, who is a pediatric cardiologist and a clinical instructor at the Children's Hospital of Philadelphia. Becky is a co-fetal cardiologist. I followed your work on placentas and congenital heart disease with great interest over the last couple of years. So we were thrilled to be able to feature your most recent manuscript in JACC, titled Placental Malperfusion is associated with adverse outcomes in congenital heart disease and with genetic variants and placental developmental pathways. Welcome, Dr. Josowitz. It's wonderful to have you with us. Becky, to begin, could you share some background on the central question that you and your team set out to explore in this study and how you approached it?
So first of all, I just want to thank you, Emily and JACC, for the invitation to talk and for highlighting our work today. So our interest in the placenta and the prenatal environment in congenital heart disease really stems from the fact that despite decades of advancement in both operative and postoperative management of these patients, there's still a high morbidity and mortality. And there's been a lot of work over the last decade or so that has implicated the prenatal environment and placental development in particular in adverse outcomes in congenital heart disease, and shown that it's more prevalent in congenital heart disease than folks that don't have congenital heart disease. And so that's really where our interest comes from, is we believe that the prenatal environment may be sort of the next frontier to explore to improve outcomes for this population. Our study really focused on placental malperfusion. Placental malperfusion is seen in disorders of placentation, such as preeclampsia, and it really refers to the effects of impaired perfusion to the placenta from either the maternal or the fetal side, and that causes hypoxic ischemic injury to the placenta and impaired placental function. And what we wanted to understand is better the relationship between placental malperfusion and outcomes in congenital heart disease, and also delve into the mechanisms of how this is occurring and why this is occurring in congenital heart disease in particular. And this study really could not have been done without the resources of the birth defects biorepository that we have at CHOP. It's a really unique wealth of information, of clinical information and patient samples, both from maternal clinical information, fetal clinical information, as well as cord blood is collected, placentals are collected and undergo very thorough analysis, and we collect samples for further research study. And then there's whole genome sequencing that is performed on the fetuses and their parents as well. So it's a huge wealth of information that we were really able to and fortunate to take advantage of for this study.
Thanks, Becky. So obviously you had a tremendous amount of data from pregnancies complicated by congenital heart disease as well as healthy controls. What do you see as the most important findings of your study, and what's the key takeaway for readers?
Yeah, so I think there are a few key findings. I think firstly, we confirm and we sort of have added to prior data to confirm that placental malperfusion is actually quite common in congenital heart disease. And in our population, about half of all patients had placental malperfusion. And it appears that it's not just restricted to certain types of congenital heart disease, but it's equally prevalent in many forms. Our study in particular focused on more severe forms of congenital heart disease that needed to be delivered at CHOP, but other studies have found similar rates of placental pathology even among more milder forms of congenital heart disease. So it suggests that these effects are likely pretty widespread among the population of those with congenital heart disease. And then secondly, we expand on the known implications of placental malperfusion and show that there's an array of adverse outcomes. So fetuses that have placental malperfusion and congenital heart disease have impaired fetal growth, they have longer hospital stays, and they have a trend towards increased mortality that seems to be independent of other known risk factors for adverse outcomes, including the presence of a genetic syndrome or single ventricle physiology. And then lastly, we provide some insight into the mechanism of placental malperfusion in congenital heart disease. So we looked at genetic variants, and we found that de novo genetic variants in key placental developmental pathways, such as Notch signaling and extracellular matrix regulation, are associated with placental malperfusion in congenital heart disease. And fascinatingly, actually, many of these affected genes are known to play key roles in placental and cardiac development, suggesting that in some cases, genetic variants in these mutually conserved developmental pathways between the developing fetal heart and placenta could actually lead to maldevelopment of both organs.
What a great summary. Thanks, Becky. Were there any results that surprised or challenged your initial hypothesis?
So I think I was surprised by the effect on mortality. We had prior evidence that placental malperfusion impaired fetal growth, and there's other evidence that an adverse or impaired maternal fetal environment is associated with increased early mortality in hypoplastic left heart syndrome in particular. But what surprised me in our study is that we found that in the presence of placental malperfusion, there was increased mortality at 1 and 3 years follow-up, but not much of a difference earlier on at 30 days. So it suggests that the presence of placental malperfusion can have delayed, longer lasting adverse effects. And then the other surprise maybe was that we initially hypothesized that we would find an increased burden of genetic variants in specific angiogenesis pathways. And we hypothesized this because of the known dysregulation of pro and anti-angiogenic factors that are seen in disorders like preeclampsia, but also in isolated congenital heart disease. And so when we looked at those particular variants, we actually found a similarly high prevalence or burden of variants in those particular pathways, whether you had or did not have placental malperfusion. But instead, we found an enrichment of variants in other pathways. So these are some of the ones I mentioned, the Notch signaling pathways, extracellular matrix regulation, and epithelial to mesenchymal transition. And it turns out that many of these genes actually do ultimately regulate vascular development, but they also directly control trophoblast, endothelial, and cardiomyocyte function and differentiation. And these pathways are actually very conserved developmental pathways that are shared between the developing placenta and fetal heart. So for example, in the placenta, Notch signaling is required for trophoblasts to adopt an invasive phenotype and invade and remodel the maternal uterine spiral arteries, which also requires remodeling of the extracellular matrix in the maternal decidua. And when that doesn't happen normally, you get hypertensive disorders of pregnancy like preeclampsia and evidence of placental malperfusion. And in the developing heart, these similar pathways are actually responsible for remodeling cardiac extracellular matrix. They control cardiac cell fate decisions, valve formation, outflow tracts. And so they're really, really crucial to the development of both organs. And I think if we had just limited ourselves to looking at specific angiogenesis pathways, we would have missed the involvement of these other biological processes.
That's great. If we switch gears a little bit and talk a little bit about implications of your work, how do you think clinicians caring for patients with congenital heart disease, either in the fetal or the neonatal period, should incorporate these findings into practice? And specifically, what role do you think placental pathology or Doppler indices might play in prenatal or postnatal risk stratification in congenital heart disease?
Yeah, so I think at this point, routine testing of genetic variants to explain placental dysfunction is a ways away. I think the biggest takeaway at this point is that abnormal placental development can lead to adverse outcomes in children with congenital heart disease. And because we understand that now, we really need to start incorporating the routine assessment of the placenta into our fetal evaluations. So we know that there are some sort of better characterized ultrasound-based assessment of the umbilical vessels, which are already routinely assessed as part of a fetal echo. And when they're abnormal, they're highly suggestive of placental pathology. So for example, decreased diastolic flow in the umbilical artery reflects increased downstream placental resistance, while increased diastolic flow in the middle cerebral artery reflects compensatory cerebral vasodilation, typically in response to hypoxia or decreased blood flow. And these Doppler profiles are routinely obtained during a fetal evaluation. And so if you see these abnormalities, they're strongly suspicious for a placental abnormality, especially in the setting of fetal growth restriction, and can be incorporated, I think, into counseling at this point. We already counsel that findings or adverse outcomes like prematurity and low birth rate are associated with adverse outcomes. And in many cases, placental pathology is probably causative or contributing to these things. And so I think as we learn more how to identify placental dysfunction in congenital heart disease, it's reasonable to include it in counseling. There are some other sort of more research-based methods that are being used to try to identify imaging biomarkers of abnormal placental function in utero. So we've done some work to show that second trimester umbilical vein flow is abnormal in congenital heart disease. Others are working on things like microvascular flow and measuring placental size by 3D ultrasound or MRI. And so work is really ongoing to correlate these findings with placental pathology and outcomes. And I think by linking those imaging biomarkers with molecular biomarkers that will be identified by using things like genomics and other multi-omics approaches, that will really be powerful to use to identify which patients are affected and how we can risk stratify and prognosticate for these patients.
Thanks, Becky. As we think ahead to the future, what do you see as the most important next steps or directions for future research?
Yeah, so I think there are three sort of major areas to focus on for next steps for future research. So I think the first is better defining the population who's at risk. So are there certain types of congenital heart disease because of differences in fetal hemodynamics and oxygenation that may be more susceptible to adverse outcomes from these placental malperfusion defects? Are there maternal factors, clinical or sociodemographic factors that are associated with an increased risk for placental malperfusion when there's congenital heart disease present? As well as the association with genetic conditions. Are there specific genetic conditions that are more at risk for having a placenta with abnormal development? And I think many of these questions would benefit from larger cohorts and ideally multi-institutional studies. I think the next step is identification of these biomarkers that I had mentioned. So both imaging and molecular biomarkers. Many groups are working on some innovative strategies by both ultrasound and MRI-based technologies to better evaluate placental structure and function in utero and really be able to identify placental malperfusion earlier on in gestation. And the combination of using these imaging biomarkers with molecular biomarkers that are identified using molecular approaches like multi-omics analysis, combining genomics as well as transcriptomics and proteomics, for example, that would be very powerful. And I think also importantly, these molecular mechanisms may differ by congenital heart disease subtype. And there is some evidence to support that despite having similar prevalence of placental abnormalities, the underlying mechanisms may differ with underlying type of congenital heart disease. So that would be very important to flesh out. And then lastly is really translating all these findings into an interventional approach. So I think it may sound far-fetched to think that we could possibly improve placental function in utero, but we know from the maternal fetal medicine community where they've leveraged their understanding of molecular biomarkers of placental malperfusion conditions to introduce widespread use of aspirin for prevention of preeclampsia, for example, as well as more recent targeted therapies. So there's a clinical trial for maternal vascular endothelial growth factor gene therapy for severe fetal growth restriction that's going on. So I don't think that it's that far-fetched. And several other groups are working on innovative drug delivery methods for the placenta. So I think placental therapy to improve placental blood flow in congenital heart disease is feasible, but it does really require us to be able to identify the at-risk population through early imaging early enough to intervene.
As you think about some of the other literature that's been published in the maternal fetal environment and congenital heart disease, how do your findings kind of fit into that broader narrative? And where do you see the field heading in the next 5 to 10 years?
Yeah, so I think ultimately the prenatal environment is sort of the next big untapped area for investigation and innovation to improve outcomes for congenital heart disease, both in the short and the long term. I think and I hope we're headed towards incorporation of routine assessment of the placenta into fetal evaluation, and then incorporation of this into risk stratification for our patients. And then I think down the line, we'll hopefully see clinical trials of agents that can improve placental blood flow like aspirin, but hopefully even more targeted therapeutic interventions based on molecular biomarkers that we can identify.
Thank you so much, Dr. Josowitz. I learned a tremendous amount talking with you today, and I would encourage anyone who is interested in this topic to look for Dr. Josowitz's paper and an upcoming edition of JACC.
Thank you so much, Emily. It was a pleasure.